May her gentle soul rest in peace.
Amen.
So, as we get more information from the family, we'll share with other members on the platform. So today, we have a presentation to be made by a hematologist from LASUT, sorry. And unfortunately, Dr. Odushote, who was supposed to lead this program today, had an emergency, a family emergency. So he's asked me to tender his apology. He might join us sometime later in the day. The moderator for today is Dr. Olaide Stephen. And I will hand over to Dr. Olaide Stephen to introduce the guest lecturer and the topic. Dr. Stephen, over to you if you are on.
Good afternoon, everyone. My name is Dr. Olaide Stephen, and I'll be the moderator for today's meeting. Thank you, everyone, for joining us and for joining early. So I'll be introducing the guest speaker for today. Dr. Motunrayo Adekunle is a pediatric oncologist at the Lagos State University Teaching Hospital Ikeja, where she combines clinical practice with research, teaching, and advocacy. Her specialist training includes a 2-year fellowship in pediatric oncology at the Red Cross War Memorial Children's Hospital in Cape Town, South Africa, which is a leading pediatric cancer care in Africa. She's an active member of the International Society of Pediatric Oncology. She has served on its scientific committee and contributes as a peer reviewer for leading journals. Dr. Adekunle's academic contributions are extensive, with over 40 peer-reviewed publications spanning clinical research and global oncology. Her work focuses on bridging disparities in childhood cancer outcomes in Nigeria through advocacy, training, and capacity building. So I would like for us to, if we can, clap our electronic hands for the presenter, which is Dr. Adekunle, as she shares her screen. So the topic for today is enhancing survival in pediatric acute leukemia and the critical role of healthcare providers. Thank you very much. And please, let's keep our questions for the end of the presentation. We'll take questions afterwards. Thank you very much. Over to you, Dr. Adekunle.
Okay, good evening. Am I audible?
Yes, you are.
Okay. Good afternoon, everyone, the elders in the house and fellow colleagues. Indeed, a great privilege to be talking to you about childhood cancer, enhancing survival in pediatric acute leukemia, the critical roles of healthcare providers. I won't be going into so much details of what acute leukemia is about, because I know we know so much about that. But I am so much particular. I'm very interested in the fact that we need to change the narrative of acute leukemia in Nigeria. And I'll be projecting and discussing with you all what we should do differently to ensure that we increase the survival. So I love always to start any of my talk about childhood cancer with this: no child should die in the dawn of life. That is by Danny Thomas. And that is, the founder of St. Jude Hospital that we all know. The beautiful thing is that he didn't talk about kids in US, he's talking about children globally. And the dawn of life is the early stage of their life, when they are to aspire to dream. So what are we all doing differently to ensure that these kids survive? So acute leukemia, it's now a global burden. Before we talk about the fact that childhood cancer is rare, yes, you can say that in relative to adult malignancy. But when you're talking about countries where majority of the population are kids, then we need to put that into perspective when we talk about the rarity. Acute leukemia, it's not rare as we think it is. It's actually the commonest hematologic malignancy and even commonest malignancy in some parts of the world. It's diagnosed in children. It accounts for about 25% of childhood cancer. So it's actually not rare. And usually the peak incidence is 2 to 5 years, that formative age, which is actually very, very critical. There's been actually an increased incidence of acute leukemia globally. You know, in US, they are talking about increase from 17.13 per thousand to 25 in the last 1 year. In Nigeria, we actually do not have a national cancer registry for us to practically say that this is our trend. But one thing I keep telling people is that if you look at the population of Nigeria and you look at children of 105 million, then if this if cancer like this, acute leukemia, it's commoner in children of ages 2 to 5 years, then you can picture how many of these kids, you know, are in Nigeria. And the fact that majority are not diagnosed, not only because we don't have the cancer registry, but also because some of them don't even get to the hospital for them to be treated. And, you know, this is just a picture for us to see that. Look at our home graph. Look at the pictogram. Majority of our population are children. And, you know, compared to US, and these people have so much, you know, given all effort to reduce acute leukemia deaths. What are we doing in Nigeria to make sure that the narrative is similar to that, knowing that most likely we have a higher burden, only that we are not just recording them? So I decided to show some data from Nigeria in lawsuits in the last 3 years, between the year 2023 and 2025. You could see that ALL and AML, which are the commonest hematologic malignancy, that means the acute leukemia, they accounted for majority of, you know, our own diagnosis. In the past, we used to talk about, bucket leukemia. Yes, it still exists, but not as we used to talk about in the past. Why? Because this is the era of hearts. So all the HIV-related malignancies are no longer so much common as it used to be in the past. So in the South now, we see more of ALL. In some other parts, they see Wilms tumor. But just for us to understand that acute leukemia is actually something common and, you know, something we should address. In this diagram, we did a study. You know, we talk about Global Initiative for Childhood Cancer not in Nigeria. This is an initiative by WHO. What are they trying to achieve by the year 2030? That means in 4 years down the line. They want to improve the outcome of childhood cancer to at least 60%, looking at 6 major malignancies, of which ALL is one of them. And now we did a study just to say, what's our baseline regarding these 6 malignancies? Where are we in terms of their proportion and in terms of their outcome? And you can see that, yes, in the southern parts, this study was done across the 6 geopolitical zone of Nigeria in some centers. In the southern part, we have more of ALL compared to the northern part, where the bucket leukemia and the Hodgkin's lymphoma still exist. The ALL still account for the majority of the malignancies that we saw in that study. So that tells us that for us to address not only the GICC goal in 2030, but also to improve the outcome of childhood cancer in Nigeria, we can't neglect acute leukemia outcome in terms of what we do differently to change the narrative. Looking at the survival rate, so much wide disparity. We talk about the high income countries, 90% survivor, even in some countries up to 95%. But sadly, where majority of these kids resides, which is the African country, we are still talking about 20% survivor. Understanding the fact that 80% of these malignancies are in sub-Saharan Africa. There's actually recorded decline mortality in high-income countries to 66%. So they are getting many of them out of this with curative intent. So how about us? How are we faring? What are we doing to make sure that we close this huge gap? The surveillance epidemiology and end result is actually a data institute by National Cancer Institute. They gather data, look at what obtains in different parts of the world. And as far as that data is concerned, the sub-Saharan Africa still account for majority of mortalities when it comes to acute leukemia. There was a study that was done in the northern part of the Nigeria, and the mortality from ALL, it was over a 10-year study. A recent study published was still 55%. In this GICC study that I said that we did, this is just a graph, a table to show us that, look at it, the mortality from ALL. Let me try and use my, okay. The mortality from ALL is still the highest compared to all the other 5 diseases that we are trying to work out to attain a goal in the year 2030. So let's look at why is our outcome what it is, and how do we contribute as healthcare professionals into this outcome? Yes, we know majority of why we have what we have. We do. We know the fact that there is delayed diagnosis in majority of our cases. Like in the study we did, the mean time of presentation for a child with ALL was 60 months. That's huge compared to developed countries where they are talking about less than 2 weeks. The referral system is usually quite poor. When you're talking of a child with acute leukemia, it's just beyond writing a letter to say, oh, go to this center. There is need for that communication, to make sure that there is smooth transfer of that patient. We talk about lack of blood and blood products, and this is actually one of the commonest causes of treatment-related mortalities. As oncologists, we look at if a child is going to die, how many of them will die from the disease? How many of them will die from your treatment? The fact that some of these kids die because of no blood, no platelets, impacts their survival, and it's one of the common causes of mortality. You all know that in Nigeria, out-of-pocket finance is still the norm when it comes to child leukemia. So you see some parents, they are willing, but they cannot cope. They will start, but they will stop. Some will start, they will abandon treatment, and by the time they are presenting, again, it's actually too late to do so much for such kids. So it's actually a major thing. Sometimes we have scarcity of chemotherapy. I remember a number of times that we're looking for asparaginase, which is actually a core drug when it comes to treatment of acute lymphoblastic leukemia. Treatment abandonment rate in Nigeria is huge. Different studies have been done, to look at the prevalence of treatment abandonment rates. Even in the GICC study that we did, treatment abandonment was about 50% of those cases. That's actually huge. So that actually also impacts the outcome of these kids. The lack of national registry. What does national registry do? When you know what the problem is, you will be able to say, this is where we need to channel our strength or our resources into. But when nothing is being said or little is said about it, number one, about childhood cancer, about which one is commoner, and about the causes of death, it makes it difficult to prioritize resources to make sure that those issues are handled. Then lack of protocol uniformity. So you find out that in many developed countries, there's an established protocol, and that's what every institution follows. But in Nigeria, we are yet to get to that stage where we all follow the same protocol to see that every child, irrespective of where that child is getting the maximum treatment. So now, I brought up the slide for us to talk as healthcare professionals. Late presentation is a major problem in Nigeria, no doubt. But that applies more to solid tumors. So you'll find parents, they can stay at home with a mass for months, even 1-2 years. For a child needing blood, we definitely have that blood in one form of hospital or the other. So why should a child have 2-3 units of blood or even more in one hospital? And the healthcare professional is just still thinking of malaria. So when it comes to acute leukemia, it's not just the parents presenting late. Sometimes it's the healthcare professional not referring at the appropriate time. And this actually affects the outcome. I'm going to show you some of those cases, of some referrals that we got. So this is just a talk for us to understand that individually as healthcare professional, we have a major role in improving the outcome of these kids. Malaria will not result into multiple blood transfusion at the same time, not likely. Yes, we have sickle cell anemia. Most times before we give the blood, we would have taken the sample. And the moment it's telling us that, oh, this is not a sickle cell anemia patient, then we need to think, are we dealing with something that is worse than malaria that we all say it is, and that child needs for that care? Will the fever subside with multiple antibiotics? The answer is no. So sometimes I've gotten call of, oh, I have this child. The person is actually thinking of leukemia, but oh, I'm waiting for blood culture results. Or I'm waiting for the fever to abate. Forgetting the fact that fever is actually a presenting complaint. It's a disease. It's one of the things they present with. So if you actually don't start the chemotherapy, that fever will not abate. So many times you don't have to wait to say that, oh, I'm treating for weeks for me to make sure that the fever, abates before I refer. And then the referral chain, like I earlier said, there is need to follow through to make sure those kids get to, the center you are referring them to. I've seen situations where parents were given referral letter, but went home for some weeks before coming. So there is need for that, referral chain to be smooth enough that that child gets care immediately, that child leaves the center he or she is coming from. So I brought up some clinical scenarios, which are actually things, I've seen, just for us to understand that sometimes the delay is from healthcare professional. So this 4-year-old boy has had recurrent fever. That was what the referral letter said, and multiple neck swellings, which were actually significant lymphadenopathy. The white blood cell count that was done from that center was actually high. As you can see, the child had hyperleukocytosis and low platelets, but good enough platelets, right? And anemia. He was given blood. Sample was sent to another center for peripheral blood film, and they were awaiting result for 2 weeks of the peripheral blood film before that patient was, eventually referred. The major thing about this is that, number one, that hyperleukocytosis is strong enough to kill that child. And until you start your drug, your chemotherapy drug, that child is not like, and then the fluid that is required, for management of hyperleukocytosis, that child is at risk of tumor lysis syndrome, is at risk of cerebrovascular accident from hyperviscosity from the hyperleukocytosis. And so they are not the type of cases that, should stay when they are not going to be managed in that center. The best is to start the fluid. And if the child is in anemic heart failure, definitely to give blood and then make sure the child is referred. There was another case of a child of 9-year-old, fever, bleeding gum. And by the time I was getting the call, I had 5 units of blood and 3 platelet transfusion. We always in the past had believed that, platelet count has to be at least 50,000 before we can do a bone marrow, or we must keep giving platelets. But one thing is that with acute leukemia, especially for AML, you can give in fact thousands of platelet units, and you will not see any significant improvement. Rather, antibodies from even your blood will start developing. So what we do is normally, as we're giving the blood, we are giving the chemo. We are giving the platelets as you are marrowing. Why? Because if you don't clear those cancers, the blast cells, that platelet is not likely to recover. So at what point should any child that any doctor is suspecting to have acute leukemia should be referred? The moment this child is stable enough to be moved, and the right communication has been made to the appropriate center that child should go to, then it's safer for that child to go. So that will reduce, the time, the waiting time to start treatment. One major thing about acute leukemia, we have phases to their treatment. There's what we call induction phase. That's the first block of chemo that we give. And that phase is a major prognostic factor in outcome. If you get it right, that child most likely or should survive. So we every kids we come in contact with, that timing to make sure that induction phase works well. So what are the roles of healthcare professional, in changing this narrative? What do we have to do to change this outcome? We all understand this that if we keep doing something the same way, we are not likely to get a different result. But I'm sure as healthcare professional, we want a better story, better narrative when it comes to acute leukemia. This disease knows no race. Yes, some talk about the fact that maybe socioeconomic class, but it's not been so proven in children. And so we've treated the rich, the poor, even kids of colleagues. And so we need to come into that position where we all say, come. In Nigeria, we have to do something else. We must change this narrative. No parents should hear, apology, your child has ALL, and the next thing they think of is death. Because that's not what it is outside the country. Even in some African countries, the outcome is far better than what we are getting in Nigeria. So what should we start doing differently or improve on? Let me start with the last one, being an advocate and the strong desire for us all to change the narrative. These parents will bring their kids to us. We need to start seeing acute leukemia as a curative disease, because it is 95% curable. It is. Because if we don't see it from that angle, then we will not, put in the measures required for us to ensure that every child we come in contact with, has that positive result. So having that strong desire as Nigerians, changing the narrative, you have come in contact with a child that you think is acute leukemia. What do we say to the parent? It's not a death sentence. They can live, they can be cured. They just need to do some things right, and we need to do some things right. So, as I said earlier, we need to stabilize them so that they get to where they are supposed to be treated. Sometimes we don't have to give blood. How I explain? I'm saying this because we've seen some kids come in perhaps worse than they should have because of the blood transfusions. So white blood cell on its own, those cancer cells, remember they are blood cells. They are, if I call them many for nothing, that's why I tell the parents, because they're like, the white cell, you are talking of white cell fighting infection, but now this is why it's not fighting infection. They are just there, they are not doing anything. But they are causing viscosity. They increase the viscosity of the blood. So if a child has aqueous leukocytosis and we keep transfusing, we worsen that viscosity. And sometimes some of those kids will just convulse, become unconscious, and they die. So when we have patients with hyperviscosity and hyperleukocytosis, you will only transfuse when necessary. So the child is in anemic heart failure. You want to take the child out of anemic heart failure. You want to give your whole blood, and they are not the ones you want to do 20 mils per kg. Remember, you are not correcting the anemia. The anemia is there because of the disease. You are just trying to get that child out of anemic heart failure. So we must be cautious when it comes to blood transfusion, especially if they have hyperleukocytosis. Let's always remember that fever is a clinical presentation and not likely to abate without chemotherapies. So yes, you start antibiotics, but that's not the only thing that child requires. Prompt referral and referral to the appropriate place. And as I've said, let's all be advocates for these kids. Another, I've seen some kids referred after commencement of steroid. Steroid is a core drug we use, especially in the early phase, the induction phase. But the way we make diagnosis of acute leukemia, especially in Nigeria, we still rely on our normal cytology. Many of those parents cannot afford immunohistochemistry, your flow cytometry, so we still use our microscope. So the moment you have started those steroids, you've changed the picture that makes it difficult for us to be able to appreciate that, oh, these are blasts or lymphoblasts, myeloblasts. So those are kids that you hear us saying, oh, we are taking Trefine, we need more tests. And many times, most of those tests are not even done in Nigeria. They will still send them outside the country. So we need to be very, very cautious in administering steroid when you are thinking of acute leukemia before the diagnosis, except the child that has mediastinal mass and is likely to die from it, which is a different ballgame. So in conclusion, we all have crucial roles to play in improving the outcome of childhood leukemia in Nigeria. And healthcare professional, our roles are actually very, very major, and it's actually a major determinant in outcome. I pledge to do mine. I hope we all pledge to play our roles. And these are a few of the references I used. Thank you. I'll take any question from now.
Thank you very much, Mar, for that very amazing presentation. So right now we'll take any questions concerning this. Okay, Dr. Haruna Jibril, you can go ahead and unmute.
Thank you very much for the great presentation. I really appreciate that. Now, talking about early referrals, one other thing that's missing with my little experience, I'm not an oncologist, but I'm a general pediatrician with some special interest in oncology. And I've seen places where when children are referred, and I think the presenter worked in that part of Africa. I remember when we were there, if a child was referred with any form of malignancy, the tumor board will not leave that hospital until a diagnosis is established. Now, that is on the background of the fact that the community, again, is aware that there is something like leukemia that's actually affecting the children very negatively. Now, in our environment, especially here in the north, the community is not aware. They keep jumping from one health facility to another, just being transfused. And we saw a child yesterday in the hospital where such a story actually happened. So for me, in addition to what we do in the facilities, we need to actually raise awareness outside. And we owe that in terms of the advocacy that the speaker has mentioned. We need to go out of our cocoons in the hospitals to actually make that advocacy very powerfully. Again, we don't have many specialist centers for treating leukemias. What we have is just departments of hematology, oncology in our teaching hospitals. And these are, besieged by a lot of resource constraints. We don't have supplies that would allow us to establish a diagnosis very, very, very quickly. Now, there are instances where a child with suspected leukemia in a teaching hospital took about 2 weeks to diagnose, not because we didn't want to do it, but there are lots of issues that are affecting our ability to actually establish early diagnosis, early treatment. So I think in addition to what the speaker and I really enjoyed the presentation, short and sharp, I think we need to look at these aspects. Thank you very much.
Okay, thank you very much for that comment. Okay, are there other questions, please?
Hello. Can I say a few words?
Yes, sir, please go ahead.
Okay, thank you very much. To the presenter, I think this is extremely moving in the sense that it has shown clearly that you're an advocate for children who have leukemia. And I think all of us as pediatricians also should play our role, just like you said in the title of your lecture. I'm aware that we also have Dr. Stimier and Dr. Gladstone Irewele from the US online, and they also treat children with leukemia primarily as their main function. I don't know if they have a few comments just to support what our presenter has said to us today. So over to them if they are willing to talk. But I must say that I also pledge, just like you've done, to ensure that we get our children proper care and at the right time. Thank you very much.
Okay, thank you very much, sir. You can also put questions in the chat box in case you're unable to unmute and speak. Okay, Dr. Ajayi Obema, you can go ahead.
I'd like to congratulate Dr. Adekunle. She is a remarkable person whose heart is for children with cancer. I just want to thank you for this presentation. When she says advocates, I think it goes right up to the top when it comes to me to advocate in the House of Assembly for this. I think there is something going on, but I think it's something you have to move because it's very, very expensive to look after children with cancer. I know Dr. Adekunle, and we have shared some things. The patients can't afford it. Many of them cannot afford it. I was privileged in the past, many years ago, about 12 years ago, to look after some top person who had leukemia. The child was seen in Abuja, and I got this frantic call from a cousin I was in Nigeria at the time, and the child had had multiple transfusions and said with malaria. The child was flown down that night to see me, and the child had petechial rash and all the rest. There was a petechial bleeding into the skin and all the rest, and was jaundiced. We decided to do I couldn't do it that night. We got the full blood count done that night, and we didn't get the results until the morning. Child's platelets were 13. So we had to get the child in. Fortunately, the mother had some connections with Lagos State. So she got platelets. She bodily went to get the platelets, and we transfused that child. These people are very wealthy, politically connected, and they're out of the country within 48 hours. They stabilized the child, platelets were in, the child went out of the country, went straight home on the street. It was an AML. And this child was in the hospital many months, had a stem cell. And this child is actually in her maybe second year in university now. So I'm just trying to tell you the path, you understand? But it's very, very expensive. Dr. Adekunle shared with the challenges that they face with children with cancer. And I think it's all hands on deck. At a legislative level, House of the same legislative level, we have to push this. The children deserve it. I also believe that we can actually see how we can link up clinical trials outside the country. So whoever has connections, the clinical trials going on in the States, the clinical trials going on around the world, how do we link some of these children up to these clinical trials? So I just want to thank you. I thank you, Dr. Adekuni, for this beautiful presentation. The whole issues about blood transfusion, that get our blood transfusion service up and it must be ready to look after these children. Thank you.
Okay, thank you very much. Dr. Adekunle, I don't know if you can see there are some questions that are in the chat box. Dr. Ogene Kowe, I apologize if I didn't pronounce your name well, asked, what is the role of an exchange blood transfusion for those with hyperviscosity? And also, okay, there's a comment for the slides to be shared. Okay.
Okay, can you hear me?
I can hear you, ma.
Okay, so let me start with the first person that commented about facilities and awareness. When it comes to some places, they are going from one hospital to the other. Yes, it's actually somehow common. And I guess that's one of the reasons for having a talk like this, because it's a forum for healthcare professionals to learn and discuss. And of course, we in our individual states also need to project this. For instance, every February 15, we talk about International Childhood Cancer Day. And it's one major way to actually improve on the awareness of childhood cancer. Every one of us. On our social media platform, whichever way we can do it in a little way, it will make impact. It goes a long way. I see many countries do that a lot. And we all also can start like that, to let people understand that this exists. Even in developed countries, it's not all centers that treat childhood cancer. So there are designated centers where the human capacity, the infrastructure and everything is there. But the outcome is still extremely good. Why? Because the referral chain is actually appropriate. So that's why we need to understand, know our limits and know when to refer. Thank you, Dr. Obima. Yeah, clinical trials, important. Number one, it's one way that those kids get to have some of this treatment free. And, because in Nigeria, we most times don't do further testing. So you can't actually look at the genetic components when it comes to some of these diseases. For instance, now, there's a patient, 2 kids under our care, both ALL. Definitely, it's likely not to be a coincidence, perhaps something genetic. So yeah, clinical trial helps when it comes to that. The question on exchange blood transfusion, yes, it helps with hyperleukocytosis, no doubt, but it's not a routine thing. One thing about the hyperleukocytosis in ALL or AML is that the moment you start your fluid hydration, and you're taking all your sample and you start your steroid, the white cell crash. So it's not all of them that you will end up needing to do exchange blood transfusion, but it's one of the ways you can use to bring down the white cell count. I'm not sure. Dr. Laide, are there more questions on the chat box?
Okay, no, that's all. Someone is raising their hand. Dr. Gladstone, please, you can unmute and ask your question.
Yeah, actually, what I have is more comment than question, and I appreciate the opportunity and your effort to raise basically to advocate for children with cancer. One, as part of my experience, I was a LUT resident. I was a resident at LUT years ago. I'm an oncologist in Houston. And one of my experiences has to do with establishing pediatric oncology programs from my institution to Kampala and in Dar es Salaam. I remember 7 or so years ago when we first started focusing on pediatric oncology at Makerere University in the Mulago General Hospital and the Cancer Institute there, the average time to diagnosis of leukemia was minimum 2 to 3 weeks. And like the other commenter mentioned, the Africa issues are, there are Africa issues. I think issues related to resource deficiency. We noted that the time to referral was very long. Average time to diagnosis was 2 to 3 weeks. But I can say now that within a year or so, and over the last 6 years, a child presenting in Dar es Salaam, or especially in Mulago in Kampala today, with suspected leukemia will be diagnosed on the same day using flow cytometry. And none of these technologies and the personnel development required, currently does not require any contribution from people outside of the country. Regarding the raising of awareness of the doctors, the other really impactful move was to establish a formal pediatric hematology training program that accepted residents, pediatricians. In East Africa, pediatricians just do 3 years of pediatric training. And so that we need to seize the opportunity in Nigeria where people who become senior registrars who, after their part 1, can actually then focus on pediatric hematology or some other specialty in a formal way. And by formal, I mean a system of lectures and a structured training program. And that is what we've actually established in Kampala and in Dar es Salaam. It is interesting to me because at the time we started the program in Kampala, as somebody who was born in Lagos and who understands LASUT and LUT really well, I felt that 7 years ago, there were more resources to formal training of pediatric oncologists and hematologists in Lagos than in Kampala. But today, I can tell you that the fellowship program in Kampala has 2 Nigerian pediatricians who have flown all the way from Nigeria to train in that program. And 2 years ago, we also trained another doctor who came from Abuja to train. And I wonder what the postgraduate college is doing to formalize the training. Because what I've also seen in Uganda is that as the training became more formal, as local doctors acquired competence in treatment of pediatric oncology and diagnosis, the awareness across the whole pediatric professional community went up. And then, just so that I don't take up all the time, I'll need to also let you know that imagine that you know already that the International Society for Oncology meeting is going to be in Abuja later this year, and that our institution, with doctors from South Africa, Kampala in Uganda, and in Dar es Salaam, we have an international Zoom-based tumor board conference every Tuesday. It'll be about 2 or 3 o'clock in 2 or 3 o'clock Nigeria time, 4 p.m. East Africa time, and which actually delves into the specific issues, the specific challenges of oncology in Africa. The recent topics included things like delays of radiotherapy in kids with Wilms tumors, the problem of money and loss to follow-up of kids, so that Africa-specific issues. And so if anyone who's interested in the oncology community in Nigeria to sign in and participate in this patient care conference, I'll be happy to share the Zoom link. Once again, thank you for bringing focused attention to the big challenge of pediatric oncology in Nigeria. Appreciate it.
Thank you very much, sir. We appreciate that comment. Okay, Temi Ademison, you can unmute. Dr. Ademison, Temi, you can
Yeah,
unmute.
thank you very much. Thank you for your presentation on this and Gladstone. Thank you for your comments. I think that we have tried a lot in University of Lagos Teaching Hospital to establish a training center. It is the problem of Nigeria and a lot of rules put in place to prevent things from moving. We are hoping that very soon at the Lagos Teaching Hospital, we are going to start our fellowship. Gladstone, you are involved in it to some extent, and I think we dropped off while you are doing the training in Uganda. I think Uganda, yes. So the issue in Nigeria is everybody staying in the cocoon and doing whatever they want to do there. And we need to come together to, to be able to move forward in this country. Right now, we have the NISPO, Nigerian Study for Paediatric Oncology, where we are trying to get things done. Atmosphere is also there, trying to get our SOPs, trying to get, guidelines for treating different cancers in children, modify guideline, of course, and then move on from there. But majorly is the problem of Nigeria trying to work in silos, and we need to overcome this. Recently, we have also had the opportunity of because the speaker was talking about getting data, we had the opportunity of having the first population pediatric registry, which is situated in our center for the past 2 years. My prayer is that this will be replicated across the country, and we'll be able to get enough data to make an informed, a decision on what type of cancers we are treating and all that. One of the major thing that has been a problem to us is appropriate diagnosis of childhood cancer, especially leukemia. You see a child, has leukemia. Okay, yes, this is leukemia. Which type? What are the genetic modifications? What are the molecular expression of this cancer that can guide you in proper treatment? It has been a big issue. And we are not moving forward. Right now, we have had site-flow in this country that can do this, but to get someone trained to carry out this function for us has been a big problem. At the NIMA, National Institute of Medical Research, they have a big site-flow there that can do this. And at root of recent, because of our bone marrow transplant program, we also have this machine. Someone has attempted to train, and it's an issue, but I'm sure when we start this, we can start fellowship training in conjunction with some other centers outside the country, including maybe, again, we talk to Gladstone. I know you are not an oncologist, but you're a hematologist. Maybe we can go back to where we were at that time. And then we have at least one training center in Nigeria. But I believe the six geopolitical zone in Nigeria deserve a training center for pediatric oncology. And until we get there, we may not be able to make much impact on the treatment of leukemia and other childhood cancers in Nigeria. Thank you very much.
Thank you very much, sir. Thank you, everyone, for the questions and all the comments. Thank you, Dr. Adekunle, once again for that presentation. I would like to hand over the meeting to Dr. Eletu for the closing remark.
Okay, thank you very much, Sharon. It's been a wonderful 50 minutes talking about children with cancers, particularly leukemia. And just before we round up, Dr. Gladstone has actually indicated that if anyone is interested in joining the African Tumor Board meetings, please send your email to my email, which I've displayed on the chat group, so I can then forward to him, and then you can get formal invitations to those meetings. I think it's something we should take advantage of. we probably will pick up one or two things that we can then adapt to our own environment in terms of helping us, particularly because of the kind of work they're doing in East Africa. I wish we had the opportunity of having that done in Nigeria rather than going to East Africa. But I probably know one or two reasons why it didn't come to us. But it's also for us to look inwards and see what we can do to ensure that such opportunities do not elude us, that they don't go to other parts of Africa. Nigeria is such a big country. We should take advantage of every opportunity that we have to ensure that we get the better part of the stick rather than the tail end of the stick. As you probably would have known as pediatricians, the Pediatric Association of Nigeria did a very fantastic job in collaboration with IPA, that's International Pediatric Association. And as such, IPA has now extended the collaboration with Nigeria. And because of the fantastic work we did, they've now expanded that same handshake, extended that same handshake to countries like Ghana, I think Uganda, and another country. And Nigeria is supposed to supervise these countries. So we're such a big country and we shouldn't miss any opportunities at all. So I want to thank the presenter, Dr. Adekunle, for, again, bringing to our consciousness the need for us to advocate for our children, particularly those with leukemia, and for us not to be, as primary caregivers, not to be one of the reasons why these children died because we failed to refer them on time. Wherever we think these children have leukemia, we should call the appropriate units and then hand them over. And it's also important that we, like she rightly said, we follow them up to ensure that they get to the center where they're supposed to receive care. The kind of mortalities we're seeing and the results we're seeing, the indices in Nigeria is really appalling. If we're talking about 20%, and 20% probably be those who can really afford, like the case that was illustrated by Dr. Ajayobi. The parents have money, so they can move. But for those who don't have money, what do we then do? We just watch them die because we don't refer them early. The little we can do, we should do. So, Dr. Adekunle, a big thank you. Sharon, thank you very much for moderating. And for all of us who've stayed to listen to this presentation, I want to say a big thank you to everyone. We hope to see you last Thursday of February for another interesting and exciting time. And thank you all. Have a wonderful evening. God bless you all. Thank you. Bye for now.